afternoon, everyone. Thank you very, very much for joining us for Advanced Echo teaching in the critically ill today. Great pleasure to introduce a great friend, Cyrus Edibaum, who's the director of Fiona Stanley Hospital over in one of my favourite places in the world, which is Perth. Cyrus was one of my consultants when I was a registrar. He's one of the first people to teach me about doing echo. And he's one of the first people to ever get, one of the first intensivists to get an advanced qualification in echo. And he got his DDU back in 2005, and he was one of the first two people to get it. And it's an absolute pleasure to have you talking to us. Thank you, Cyrus. Talk to us about LVOT obstruction. Thanks a lot.
Thank you very much, Sam. It's a pleasure to talk for your wonderful DDU lecture course. It's amazing you've managed to put up something that's so widely accessible and put a lot of time and effort into it. So Sam's asked me to talk about left ventricular outflow tract obstruction. So I don't want to try to teach anyone to suck eggs, but I'll start from the basics of outflow tract obstruction, just go through some of the mechanisms, talk about the etiologies, both HOCM and non-HOCM related, then go through a sort of bunch of images and then some cases, and then sum it up with a nice little case at the end that demonstrates the challenges in this area. So feel free to stop and ask and let me know if there's any difficulties in seeing the slides or the images. So I'm hopeful that the slides will play and not buffer too much over the internet. Okay, so the important things about outflow tract obstruction as we talk about it in the context of LVOT is that it's dynamic, and that means it's a variable obstruction of the outflow of the ventricle induced during the process of LV ejection. And it's important to know that the obstruction can occur really anywhere in the ventricle, most commonly in the LVOT, and there's the term DLVOTO, or dynamic left ventricular outflow tract obstruction, but equally it can occur in the mid cavity and also in the apex, certainly in the HOCM zone. So dynamic outflow tract obstruction occurs, it's very complex interplay between various anatomical aberrations associated with various pathological states and also complex hydrodynamic forces. So as I said, there's both HOCM and non-HOCM related etiology where you can see outflow tract obstruction, and rarely in the absence of any cardiac disease you can sometimes see it. So the nub of it involves systolic anterior motion, or SAM, of the mitral leaflets or the mitral, any part of the mitral apparatus, be it the chordae or the papillary muscles, that move forwards towards the septum during ejection, and this reduces the area through which the blood flow is ejecting, which then induces a gradient. So there's no real definition of what's a significant gradient and what's not, but generally, if you've got a reasonable or significant left ventricular outflow tract obstruction, it's going to be somewhere between 30 to 50 millimetre mercury gradient. Certainly over 50, you're going to see hemodynamic consequences. Under 30, it's unlikely that it will cause major problems, but they're just ballpark figures. So from the critical care clinician perspective, the important thing to know is this is clinically occult, and it's often a cause of hypotension and shock that goes unnoticed, often till it's too late. It's also can be transient, and it's very unpredictable. And most of our standard approach to managing hypotension and shock actually makes it worse. It creates a death spiral of worsening hypotension if you don't recognise it. So you really have to have a high index of suspicion to pick this up. You need to be able to drive an echo probe, and you need to know the groups of patients who are likely to develop SAM. Now, certainly in the post-operative cardiac surgery arena, we used to be surprised, get caught out a little bit, particularly after mitral valve repairs in the days before there was intraoperative TOE. But SAM is now picked up very early in the course of cardiac surgery, and things can be done about it even long before the patient gets back to ICU, which wasn't the case about 15 years ago. It was all a bit new to us, this whole concept of outflow tract obstruction. And equally, finding SAM on echo, you'll often see some people get really excited when they see it and they think, you know, that's the cause of all of the patient's ills, and often it's not. So we can also over-attribute the clinical state to SAM when in fact it has really no implication in the patient's current state. So the classic sequence of dynamic left ventricular outflow tract obstruction is the eject, obstruct, leak sequence. So during ejection, the mitral leaflets or subvalvular apparatus move towards the septum, and that's a combination of malaligned ejection forces pushing it towards the septum, as well as a Venturi suction effect. It was always thought to be a Venturi suction effect, but it's a lot more complex than that. But it really doesn't matter to us as clinicians, whether it's a push force or a sucking force. The effect is the same. So as mentioned before, it causes a progressive narrowing of the outflow tract with maximal obstruction occurring in mid to late systole. That movement of the mitral valve leaflets or apparatus then induces malcoaptation and results in an eccentric and most often posteriorly directed mitral regurgitant jet. So as mentioned before, you get the classic clinical picture in ICU of worsening shock with increasing inotropic therapy. So the dobutamine and the NORAD's going up and things seem to be getting worse. And some of the more astute people who can still use a stethoscope, I can't, may be able to pick up a new murmur, plus or minus an apical heave. So why does this happen? Well, you need a substrate for this to occur, and it's both anatomical and physiological. So the two anatomical substrates that are associated with that outflow tract obstruction are a reduced left ventricular endostolic dimension and anterior displacement of the mitral valve coaptation line. So the most common cause of that reduction in distance between the mitral valve, anterior mitral valve leaflet and the septum is due to thickening. And that could be, and I've got cases to show you a bit later on, of a sigmoid septum, plus or minus a steep aortic root angle, and asymmetric septal hypertrophy, which is classic of Hokum. You also see it, and it might not necessarily be at the outflow tract level, but sometimes mid-cavitary, that those little muscular hypertrophied hearts that we call the little ball of muscle hearts are susceptible to outflow tract obstruction, as well as other conditions that can cause a ventricle to be squashed up, such as cor pulmonale and occasionally tamponade. So the second anatomical substrate, as we mentioned, is the anterior displacement of the mitral valve coaptation line. And that's usually due to redundancy of the anterior and posterior mitral valve leaflets, particularly in myxomatous degeneration, but also in Hokum, where there is an anatomical abnormality of the mitral valve. And sometimes you can see it in people with really quite severe mitral annular calcification, when there's a whole bunch of limestone on the posterior annulus and it pushes the coaptation line up. It can sometimes be associated with SAM. So the physiological substrate you're all well aware of. Any conditions that reduce the end diastolic dimension of the ventricle, so preload reduction, usual stuff, diuresis, bleeding, dehydration, increased airway pressure, too much PEEP, all of that stuff. Afterload reduction with vasodilation in the systemic inflammatory response of any cause, nitrates, and then tachycardia, either consequent upon the use of chronotropic medication or tachyarrhythmias. And the second physiological substrate is when the ventricle is hyperdynamic, and that is either induced by us by giving lots of stimulatory medication, beta agonists, etc. And if you give people enough stimulus, up to 1/5 of people will actually develop SAM and LVOT obstruction. And I wrote one of these things up for my DDU case report. Was somebody, we did an exercise or dobutamine stress echo on, and they developed SAM right up at the high end of the dosing and developed a gradient, but they were otherwise fit and healthy. The second dot point there is when you get the base of the heart becoming hypercontractile. And that can occur in large anterior myocardial infarction or with the Takotsubo ballooning syndrome. You actually get a geometric change as well. That geometric change of the ventricle makes it more likely to develop SAM and outflow tract obstruction. So let's just whiz through the echo hallmarks. I'm sure you've got this down pat, and as soon as you see M modes and loops, you'll be able to pick it up really quickly. So we'll just go through that just for revision. So here with the M mode trace, the important thing is that you'll see there's a mitral valve opening. There's a sort of fairly thick looking mitral valve leaflets on the M mode, and very thick septum here. So this is a Hokum patient. You can see that during systole, as you see the posterior wall come up, you'll see there's a gradual movement of the anterior mitral valve such it contacts the septum and it stays contacted. And then you can see that degree of contact does vary depending on the beat as well. So here in this cycle, there's a fairly prolonged contact. When you look at another case, you can see here there's the mitral valve leaflet rises and touches the septum briefly and comes away, and then on another beat doesn't touch it as well. So what you look for on M mode is you look to see when the onset of the SAM is and when it contacts the septum, and then for how long, and that's called SAM septal contact duration, which is a pretty blunt marker of the severity of obstruction, but it can be used if you're concerned about whether SAM is materially contributing towards your hemodynamic status. The other hallmark M mode sign that you're all probably aware of is this mid-systolic closure of the mitral, of the aortic valve leaflets as the outflow tract gradient rapidly ramps up during the mid to late systole. The pressure distal to that obstruction drops away and the valve leaflets decide they want to close again, and then they might just briefly pop open again before they close. So that's a pretty much a hallmark sign. It's definitely a typical kind of picture that you might get presented in the exam. Can you see the video there? Yeah. So here is a 2D picture, 4-chamber view, and as you can see here, it's a fairly classical movement of the mitral valve and the apparatus towards this pretty chunky septum. And in another view, although it didn't look as significant on the apical 4, certainly on the apical long axis, you can see the systolic contact is fairly significant. So colour Doppler, we look for turbulence and aliasing at the point of obstruction. Sometimes you can see a flow convergent zone, nice hemispheric flow convergent zone around just as you go around the septum. Importantly, you'll find in significant cases, you'll get a posteriorly directed mitral valve jet, which can look pretty impressive on colour Doppler in terms of its surface area, but just bear in mind that the mitral regurgitation often doesn't start till very late in the cycle, mid to late systole. So the actual amount of regurgitation is not as much as you would predict on the basis of the colour Doppler signal. So here you can see, same patient there, you've got this mid to late systolic onset of this eccentric jet. Here's another case. Again, it's just more of a little flash, if anything, towards mid and late systole. So the spectral Doppler analysis, you'll see the classic dagger-shaped profile, which is exactly related to that mid to late systolic obstruction. You can often get contamination of the spectral profile with coexistent aortic stenosis or mitral valve, or obstruction at any other level in the mid-cavitary or the apex. So here's a fairly classic spectral profile. It's got that Bowie knife shape. Here, this gradient is 100 odd. Here's another patient where the gradient at rest was only about 30 with a classic dagger-shaped profile, and then with a Valsalva, it really increased way up. So there's a variety of ways in the echo lab you can do provocation. Valsalva is the commonest. Nitrates used to be used, not so much now. And here's a picture where there's a lot of spectral contamination. So you can see along this line, you've got your outflow tract obstruction here. It's probably going to be in the mid-cavitary because it's not actually lined up on this one. But there's 1, 2, 3 profiles in there. So this could be high up in the apex. This could be sort of as you're coming down, and this is a bit more proximal. But you often see this mixed spectral profile. So how do you manage that? Well, the important thing to do when you're looking with pulse wave is to put your sample volume in the apex and then walk your way down to the LVOT, and you watch the pulse wave velocity increase, and that's called the step up. And where you get the point of rapid step up is where the significant obstruction is. And you'll see here we've got a case with sample volumes in the apex, and even there's a reasonable gradient. We moved it down to the mid. The gradient is increased a bit, and there's aliasing there because it's exceeded the velocity threshold which we can display on pulse wave. And then into the LV outflow tract, you can see it's probably not as great as it was in the mid cavity. So you get something like this as you do it. This is a bit of a busy one, but it just shows you when you drive the sample volume from the apex through to the mid, through to the base, through the LVOT, and you want to see where the major velocity step up is. And you can see here it steps up quite significantly in the LVOT. This is a continuous wave Doppler. You can see here you've got mitral regurgitation, contamination, but you've got the classic LVOT profile there. So if we look at some of the common causes and cases, and we'll get on to a few more images now. So if you look in the myocardial ischemia and outflow tract obstruction, you see it with large anterior MI or Takotsubo or apical ballooning, which can occur together as well. And this occurs because there is this compensatory basal hypercontractility that can lead to SAM. And it's a bit of a vicious circle. You have an anterior infarct with mid and distal LV dysfunction, causes the base to hypercontract, might induce SAM and obstruction, causes mitral regurgitation, which drops after load, which increases your outflow tract obstruction, the hypotension. You see this spiral happening here. The treatment worsens it. You get endocardial ischemia, and you can even develop myocardial apical ballooning in an MI as well. So it's a bit of a spiral decompensation. So in Takotsubo, it's about 1/5 of patients will develop SAM, which leads to MR and outflow tract obstruction. So they can often present shocked, and it's more than just the reduction in ejection fraction that's contributing to it. It's often in the elderly female who also has a sigmoid septum. So here's one of the cases that we had, and from memory, it was an older lady who the afternoon before she presented, her horse had, she was a horse lover, and the horse had jumped the fence and broke its leg, but in the process kicked her in the abdomen, and she had a lot of epigastric pain. And then she presented with chest pain the next day. And the horse had been put down the night before, so she was extremely distressed, but she came in with ECG changes and shock, and went to the cath lab, and she had normal coronaries. And then in the ICU, she had this balloon ventricle and she had SAM. And you can see here, there's the balloon ventricle, and you can see the basal hypercontractility and SAM, and a little bit of mitral regurgitation. Here's a nice flow convergent zone showing the acceleration around the septum there. So for those of you who do a lot of cardiac surgery, as I said before, it's not common now to find SAM in the ICU before it's picked up in the operating room. But it's commonly seen after mitral valve repair, sometimes after mitral valve replacement, and sometimes after aortic valve replacement. So they're the sort of 3 risk groups that you need to be aware of for SAM and outflow tract obstruction. So it's a busy slide, but in the post-mitral valve repair group, only about 5% of cases will develop it nowadays. And most often, even though you might see SAM intraoperatively or post-operatively, most of the time, the SAM settles with the simple hemodynamic measures, which we'll talk about later on in the management section. So giving volume and sometimes with pacing. So some anesthesia people have tried to find out which patients are most likely to develop SAM after mitral valve repair. And Maslow had a couple of parameters that seemed pretty reasonable in detecting which people were likely to develop SAM after mitral valve repair. And essentially they looked at a couple of simple measures. They looked at the length of the anterior leaflet and the posterior leaflet distal to the coaptation point. And the more contribution there was from the posterior leaflet, and the closer that coaptation point was to the septum, the more likely you were to develop SAM. So I haven't put the cutoff figures in there. I don't know of any anesthesia people who actually measure those things, but there is a degree of predictability. But it tends to be more with the older style mitral valve repairs with rigid rings and the old style trigonal sutures that try to narrow down the mitral valve commissures. That can sometimes decrease outflow tract area. So occasionally after mitral valve replacement, particularly in those procedures where there's preservation of the caudal structures and subvalvular apparatus, you can get some impingement on the LVOT. You'll often see people with prostheses have these struts that abut the basal septum, but in my experience, it looks much worse than it actually is. So you get cases like this where you see the MVR and the strut is actually touching the septum, but it's only really a 2D image. So unless you do 3D, you won't get an idea of what that LVOT area is. But as you can see here, there's little to no aliasing around there or turbulence. And here's another case. And this one is a guy who's got aortic stenosis and had a TAVI actually put into his mitral valve. And you can see, you wonder how any flow is going to get through that. It looks like it's completely blocking the LVOT. And you can see, yeah, there's a little bit of turbulence, but not much. And then when you do the spectral profile, you can see that it doesn't look anything like an LVOT signal. It looks more like aortic stenosis. So just on the basis of that profile, you can say that's not a significant obstruction of the LVOT from that prosthesis. So following AVR, SAM is actually reasonably uncommon. And there's generally some coexisting anatomical substrate there. So there's either a sigmoid septum or there's redundant leaflets. But it's because there's this almost immediate relief of afterload following the valve replacement, combined with the usual post-op hypovolemia and sometimes dobutamine infusion, etc., that you can get this temporary SAM and outflow tract obstruction. But more commonly, you tend to get it in the mid cavity because the hearts are thick, particularly in the smaller ball of muscle hearts, as I talked about. You tend to get obstruction, but it tends to be below the level of the LVOT, and that's noted in about up to 15% of patients. So here, here's the patient with an aortic prosthesis, and you can see that there's almost cavitary obliteration post-op, and you can see some of the valve and caudal apparatus is impinging on the septum. So moving along, probably the commonest thing that we see are the people with sigmoid septums, and they're usually elderly hypertensive females with diastolic dysfunction and have the small hyperdynamic ventricle. They've got an increased relative wall thickness of the basal septum and a small outflow tract area. So this is a fairly typical sigmoid septum that you see. That's the sort of sigmoid S there sticking out. And you can see that here it sort of comes down to a tip, and you can see there the chordae and the base of the mitral leaflet has a tendency to hit against it. And here there's some turbulence and MR. And here's the toe view of someone similar. Again, there's that nice sort of bulbous sigmoid septum. So it's a fairly classic appearance. And if you see that, or if you're looking at a preoperative cardiac surgery case echo and they say they've got a sigmoid septum, then you need to be very aware that you're going to have to screen them for SAM post-operatively if they haven't already been intra-op. So less common causes of left ventricular outflow tract obstruction. We talked earlier about significant mitral annular calcification. That's where the whole mitral valve is pushed up because of the calcification. There's usually not much SAM. It's usually more of a fixed kind of obstruction. Plus you get the mitral stenosis with it as well. Cor pulmonale, there's often septal shift with the D-shaped ventricle, pushes the mitral valve leaflet closer to the septum. Plus you've also got beta agonists and things with the coexistent respiratory problems that might be current at the time. And we talked about tamponade. I don't have any echoes of those to show you. So if we talk about the acute management of dynamic left ventricular outflow tract obstruction, so the first thing is not to over attribute the SAM as the cause of all your ills of the patient. So in order to do that, you've got to try and quantitate the degree of outflow tract obstruction. And we talked about that in those previous slides. You can look at the SAM septal contact time, but most critically is to do your best to assess the severity of the gradient. And we said if you have a gradient that's under 30, it's unlikely to be causing you any problems. But if it's over 50, then it's more than likely to be contributing to your clinical picture. So the basic initial interventions you're all aware of: volume loading, increasing afterload, reducing heart rate, inotropic stimulus, beta blockers, calcium channel blockers, diltiazem, verapamil. Changing over from noradrenaline to phenylephrine, we sort of reflexly do that. Whether there's much of a difference between the two, don't know. Said to reduce the heart rate, and there's some beta-1 stimulus at higher doses that you're probably ditching. So, revascularization, beta blockers, fluids, phenylephrine, reduce your inotropes, turn off your balloon pump, stop your nitrates and diuretics.
So would you add in the importance of sinus rhythm into that?
Yes.
Yeah.
Very, very much so. Yeah, very much so. So, if you have tachyarrhythmia, amiodarone.
Yeah, I go for amiodarone pretty early with these patients sometimes.
Yeah, cardioversion, all of that. Yeah, most definitely. In the post-operative patient, often ventricular pacing can induce septal dyskinesis and move the septum away just at the right time to reduce the outflow tract obstruction. And after all of that, if you're unsure whether it's contributing, you can just try a short-acting beta blocker infusion to get the heart rate right down and see if sometimes things magically improve as you beta block. There's often a little bit of a reluctance to give beta blockers when people are on noradrenaline and things, but in the case of outflow tract obstruction, if it's significant, you'll see a significant improvement as you beta block, and you'll see the vasoconstrictor coming right down. So I'll just move on to the HOCM side of things. I don't want to make this about HOCM, but I just want to show you some images. But just briefly, we all know it's a genetic disorder. It's characterized by cardiac hypertrophy. It's generally normal increased ejection fraction and normal size ventricular cavity. And none of that's explained by loading conditions like hypotension, etc. The hypertrophy at a microscopic level is disorganized, and there's a lot of fibrosis. And the most common manifestation is the ASH, or asymmetric septal hypertrophy of the basal septum. And the thickness ratio that's said to be significant is when you get 1.3 to 1 septal to posterior wall ratio, but it's not particularly specific. However, if you see a septum that's greater than 15, 16, it's unlikely to be LVH, athlete's heart. It's more likely to be HOCM. And Sam, you may know a little bit more about that, given that you do a lot of routine clinic echo. You probably see a lot more of the routine stuff coming through. But generally, I've always been taught if you're greater than 15, you're going to be thinking HOCM.
Yeah, I've seen that before. I've often thought the same thing. I've seen similar numbers. Talking to the guys at the Mayo Clinic, they had numbers more like 18 in their practice. Because more than 15, it's not that uncommon. I think we'd see a lot more hypertrophic cardiomyopathy if we took those numbers. But I know the paper, and I kind of just go off what Jo told me, which was using number of 18.
18, yeah, okay. So 15 to 18, think about it. Greater than 18, yeah, it's more than likely. And here there's lots of lookalikes. So athlete's heart hypertension, the classic, relatively, these are not uncommonly seen: amyloidosis, aortic valve disease. You'll see the classic basal septal hypertrophy. Occasionally you'll see the apical version, which tends to be more common in the Asian population. Lateral wall, and very rarely concentric LVH or RV. So HOCM manifests with 4 things: diastolic dysfunction, outflow tract obstruction, chest pain and arrhythmias. And 70% of people don't have significant obstruction, 30% are none, and 40% only with provocation. So it's a multimodal diagnosis of LVH that you're all aware of, more than just echo. And the pathogenesis, again, it's largely the same. I mean, the same anatomical substrate, the ASH. But here there are specific mitral valve abnormalities. So elongation of both anterior and posterior leaflet. And there's some specifically documented mitral papillary muscle abnormalities, such as direct insertion or anterobasal displacement of the anterior papillary muscle. So again, the direction of ejection, instead of pushing the valve away from the LVOT, it tends to push it towards it. And you can see here from the size, I think everyone's seen this slide, you have this anteroapically displaced papillary muscle tends to pull the plane of coaptation up into the LVOT, and you get the pushing effect. You've got the ASH there, and sometimes you can see the bifurcated papillary muscles. So it's more than just this. It's to do with the papillary and the subvalvular and the leaflets. It all contributes to it. So I just dug a few out of the drawer. Some of the memorable ones. Here's a big chunk of steak and the basal septum. But as you can see, there's not a huge amount of SAM there. And if anything, maybe just on the chordae. And another one, this one takes a bit of time to load, and you can see there's sort of fairly significant SAM at the leaflet and the caudal level. And this is the same patient in the short axis, and you can see that big septum here. This is one of my very first ones back in 2003. You can see the quality of the video. This is an ICU patient that we had, and they're always memorable when you see ones like this. Here, this is courtesy of Feigenbaum, which has a mid-cavitary obstruction. It's not quite obvious on 2D, but when you chuck some colour on, you can see there that narrowing and the flow acceleration in the mid-cavity. And quite nicely with contrast, you can see that mid-cavitary obstruction. And we've got a couple here from fish. You can see that apical variant there with that sort of ace of spades appearance going into the apex. And you can see nicely with the colour that acceleration coming out of the apex. And here's the contrast study that we did. Shows you that thickening right up in the apex. So echo is really important to quantify the abnormality in HOCM, and there's various provocation studies that can be done. And generally, those people who still have symptoms despite maximal medical therapy and have a gradient greater than 50 either see themselves heading towards septal ablation or some sort of surgical repair, be it a myomectomy combined with either a mitral valve repair or a replacement. So again, this one's borrowed from Fagan bone, which is a preoperative HOCM patient. You can see the nice rounded septum. Post myomectomy is chopped away there. You can see, although there's SAM, it's not making any contact with the septum. So just another little thing that might pop up in the exam, certainly mentioned often enough when you go to echo conferences, is the combination or coexistence of aortic stenosis and outflow tract obstruction, and how to assess the aortic valve. So it's the turbulent jets from long-standing LVOT, particularly in HOCM, can damage the aortic valve and increase the incidence of aortic stenosis. It becomes very difficult then, in the presence of outflow tract obstruction, to quantitate the degree of aortic stenosis, because it's difficult to locate on continuous wave Doppler where the site of peak flow velocity is. And all of our equations for assessing valve area and gradients become inaccurate when the proximal velocity increases above 1.5. And you often have multiple traces, which can be confusing. So you can see here, this is a combined case of aortic stenosis and LVOT obstruction. But assuming that is the aortic profile, measuring that and calculating its mean gradient is not going to be accurate, because if this is the total ejection time, what happens is the aortic velocity starts to truncate very early on as the outflow tract velocity and gradient increases, so it actually stunts it. And you can see here, when you directly measure pressures, you've got gradients between the ventricle outflow tract and aortic outflow. So simply just measuring that and saying, oh, well, that must be from the aortic valve, is not going to be accurate. So here's a case where you can see a rocky aortic valve. It's also got a rocky mitral valve, and there's some SAM. And you can see there's turbulence all at the outflow tract as well as across the valve. So how do you assess the severity? Can you use planimetry? Probably not. I read a couple of papers about groups that do simultaneous catheterization of the LV and the aorta, and then beta block the patient and then remeasure the gradients and get rid of the outflow tract obstruction beta blockers. But that's only on the assumption that you can get rid of the outflow tract obstruction. So it's always been something that's been confusing to me as to how you assess it. Probably MRI. I don't know, Sam. What's your approach when you see that?
Multimodality imaging is certainly what's been suggested with MRI, CT, I guess, trying to get calcification scores, and just the modified Bernoulli equation, just transferring that to the true Bernoulli equation, taking in V1 and V2. Yeah, it's really bloody hard, I think.
Yeah. Okay, so just as we finish up here, just a slight variation on the theme, and I'm sure most of you might be able to pick this up. So I'll show you the 3 slides. So that's parasternal long axis.
Cyrus, can we pick on someone who's doing the exam?
Yeah.
Here we got Vijeth. Are you good to go? Can you hear us?
Yeah, can you hear me?
Yeah, beautiful. Hi. Vijeth, you happy to have a crack at this?
Yeah, looks like a sub-aortic membrane in the LVOT tract.
Yeah,
And if
very
you do
good.
a Doppler, probably would suggest severe aortic stenosis, kind of a Doppler profile.
Yeah, so you're quite right. It's a subaortic membrane. You can see it nicely on this view here, this little ridge coming out. But the classic thing about this, it doesn't have the same appearance of a dynamic left ventricular outflow tract obstruction. It's got a typical fixed obstruction pattern. You can see here in the LVOT looks quite normal. So that's the type of outflow tract obstruction that's non-dynamic. And I'll just finish with one case from a couple of years ago, which I thought just sort of encapsulates everything about why echo is essential in intensive care. So we had a 41-year-old guy who had HOCM, who had been in one of the private hospitals and had a septal myomectomy and a patch repair of the anterior mitral valve, which is sometimes done. They just sort of stitch it up, it almost elongate, put a patch in the mitral valve to try and drop the coaptation line. This guy, quite severe Sam. And he did well. He went home and he was doing very well at follow-up. And then one day he felt unwell, pre-syncopal. They called the ambulance and he looked pretty terrible, and they brought him into the ED, and they X-ray showed pulmonary edema, and so he was put onto CPAP and given a lot of diuretics, but became more shocked and shut down and was referred to ICU and came up in a bit of a hurry and got intubated and ventilated and put onto dobutamine and NORAD. And then a tow was done, and it showed very severe SAM. So there's the myomectomy there. It's difficult to see the mitral repair patch. This wasn't done by me. I'm not saying that for any reason. Again, this was the appearance. So it was interpreted as severe MR circulating around. So they're saying, okay, well, the guy's shocked. He's got SAM again. Let's treat him the way he needs to be treated. So let's volume load him. Let's give him a bucket load of beta blockers. Let's change him over to phenylephrine and see what happens. So this is another view. And you can see it's pretty impressive. It's almost like completely glued to the septum. And he had all of that, and he got much worse. And he started bringing out frank blood up his ETT, and both his lungs turned white and was unable to oxygenate. So he was put onto ECMO, and then we repeated the tow. This is on ECMO, and then you start to notice something funny here. So his patch repair had fallen apart. And that was the problem in the first place. So although you saw SAM, the initial echo didn't show the actual problem. His patch repair had come apart, so he had everything that was going to make mitral valve regurgitation worse, which it did. Anyway, he had a pretty stormy course, and you can see here, you can see that repair is dehisced. So his presentation was a sudden dehiscence of the mitral valve repair after that. And then he went on to have a mitral valve replacement and spent, a month or two in ICU. He lost a limb from the ECMO cannula and various other things. But if you can pick these things up as quickly as you can really make a difference to someone dying or surviving. So no sort of, nothing you don't know there. So I'm very happy to take questions.
Thank you, Cyrus. That's a pretty brutal last case. Crikey.
Yeah.
So can I just ask a really simple question just to kick things off? Just again, keep it simple. You talked right at the beginning about being able to recognize those at risk. Can you just summarize those again for me, just to get them clear in everyone's head? You know, who do we need to be going to get the, you know, the echo probe and going to assess for someone potentially for this LVOT obstruction? Who do you have on your list?
Yeah, so if you look in the cardiac surgical group and the non-cardiac surgical group, so the cardiac surgical group, obviously anyone after mitral valve repair is probably the biggest group. Anyone on their preoperative echo has the sigmoid septum, or anyone with a sigmoid septum. Elderly, hypertensive patients are really the group that you can often miss it in.
Yeah.
And then there's the undiagnosed hookums that you just don't know.
And it'd be but these guys, particularly, I guess, the ones who are on like rapidly escalating levels of inotropes,
Yeah.
also kind of kick me off a bit.
Yeah,
Someone
so
who's gone from 5 to 30 of single strength NORAD over a matter of 30 minutes.
yeah, that aren't following the trajectory that you think they should with the treatment that you've given them. So when something's odd, you're saying this is odd, you know, why the noradrenaline's going up, and there's no reason why it should, then you do an echo. But, you know, we have the sort of rationale of echoing everybody on decent amounts of, you know, anyone on 20 milliliters an hour of noradrenaline, they get an echo.
Yeah, that's true.
Yeah, you're going to miss cases otherwise.
Yeah, absolutely. Completely agree. And you can find this when you're not expecting it.
Oh, yeah.
Yeah, I completely agree.
Not so much in the cardiac surgical patients, because with everyone having intraoperative toes, pre and post bypass, it gets picked up. And the anaesthetists are very good at it now. It's the non-cardiac surgical patients that are not progressing. Yeah.
And I want to echo that, especially with the group of, you know, the elderlies having the hip replacements and actually rest on the table during inductions, and those ones are at high risk, at least put into your differentials. Is that SAMS or alpha atrial obstruction is actually one of those differential diagnoses, since the treatment is actually very different.
Yeah,
absolutely. Yeah, and those particularly, as we said, elderly, sigmoid septum, myxomatous degeneration, mitral valve leak, it's very common to see SAM after some, when you induce some sort of physiological change, be it spinal with vasodilation, or they get septic or whatever. So yeah, it's not entirely predictable. You just, as you said early on, you just, as an intensivist, you just need to have a high index of suspicion and get that out of the picture early. It's as simple as putting an echo probe on.
Thank you. Are there any other questions for Cyrus?
Hi, Sam, it's Ravi here.
Hi, Ravi.
Hi, Cyrus, how are you?
Well, thank you.
I had a question, like, can we produce a dynamic LV outflow obstruction in like predisposed patients, but by our interventions, like if we are doing, say, APRV mode of intervention and somebody with severe ARDS and we try to dry them out, can we make an iatrogenic dynamic obstruction?
Well, that's where it becomes a delicate balancing act, Ravi. You will try to achieve your therapeutic goal as far as you can before the outflow tract obstruction becomes an issue. I mean, as I said earlier, you can see SAM and it might not cause a significant gradient even with diuresis. So it's important that you measure. You do something, you measure the gradient, you diurese more, you measure the gradient again, and as soon as you see it move up, you know you're at the point where you can't push it any further. There's no easy answer. As a lot of things in ICU, you do something, you measure, you adjust.
Yeah, thanks.
I've got a question, if that's okay. It's Danielle here. Hi, Sam. Hi. Thanks so much for a really good presentation. I was just wondering what happened to the lady that got kicked by the horse, because I was reflecting that you know, what do you do with the patient? She's presented shocked with the Takotsubo. There's nothing to revascularize. Increased afterload is going to be bad for the failing heart. Filling is going to be bad. What can you do for the patient then?
She got better. I mean, she wasn't in, you know, huge cardiogenic shock needing inotropes and those things. She was a little bit shut down, but from memory, she had some beta blockade. And once we saw the SAM, again, you have to push it. It's hard. We're always taught not to give beta blockade when somebody's slightly hypotensive. But if you're happy that the LVOT obstruction is materially causing the problem, then you'll often see it improve. So yeah, she got beta block, and just like a lot of these things, with time just picked up. She did fine.
Thank you.
Does intravenous ivabradine work in this circumstance? I've always wondered.
I would think it would have the desired effect, though it probably doesn't have the effect of reducing the hypercontractility.
Yeah, sure.
Also,
it's not a negative inotrope, though, I guess. And we've probably got time for one more question if anyone would like to ask.
Hi, Cyrus. Can you hear me?
Yes, I can.
You're a bit quiet.
Hi, Cyrus. This is Shailesh here from Adelaide.
Hi, Shailesh.
I've seen kind of LVOT obstruction a few times in patients after VA ECMO decannulation, when patients who have been put on for cardiogenic shock, for example. Actually, It's not very uncommon. After we decannulate after VA ECMO, I just wanted your experience on this.
Yeah, no, I haven't seen that, but I can imagine that when you remove the aortic cannula, then you've suddenly lost a lot of that back pressure on the aortic valve. And yes, you're going to be ejecting a lot more than you would have been when you're weaning your flows right down to 1 or 2. It might look fine, and often with the ECMO weaning, when you get below 1 or 0.5 litres a minute is often the danger point.
Yeah.
So yeah, it is possible that as you take them off ECMO support, then there's much less afterload for the ventricle to contract against, and you induce SAM. It's not inconceivable.
Yep. Okay. Thank you.
Okay.
All right. Thank you very, very much indeed for your time there, Cyrus. That was absolutely amazing. And yeah, it was absolutely fantastic. Thank you very, very much indeed.
Pleasure.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.